All right, we're going to be talking about shock and multi-system organ failure on this recorded lecture. So first, these are just some resources for you to go to if you want a little more info on shock. And so let's just start off with what shock is. So shock is this life-threatening condition related to inadequate tissue perfusion. So if the body's not having adequate tissue perfusion, how's that going to affect, every organ in the body? And so what do you need for adequate tissue perfusion? Well, you need an effective cardiac pump. So you need your heart to be able to effectively get blood pumped out to the rest of the organs. You need adequate vasculature or circulatory system, and then you need sufficient blood volume. And so those three factors can be affected in patients that are experiencing shock. And so when you think shock, you just need to think there is not enough tissue perfusion happening in these patients. And so once you get to that inadequate blood flow, that's going to result in poor delivery of oxygen and nutrients. They'll have cellular hypoxia, and so not enough oxygen to the tissues is going to cause hypoxia, and that will lead to cell death that progresses to organ dysfunction and then eventually death. And so when we think about shock, our body usually is going to respond to shock by activation of the inflammatory response. We'll then have hyperperfusion of tissues, hypermetabolism. We're going to have this increased need for energy because our tissues aren't getting perfused at all. So when we look at the pathophysiology of shock, we need to look at what happens at the cellular level. And so there's cellular changes. And so when that inflammatory response kicks in, you have increased permeability. And so vessels start to get leaky. And with that, electrolytes and fluids go in and out. You can see damage to the mitochondria. You have cell death. And so if you look over here at the cell, we have, cellular edema on this right side over here where the mouse is, that kind of shows you what happens in shock. And so fluids are leaking out. We got efflux of potassium. Potassium's leaking out of the cells. Right here, it gets down to this increased membrane permeability, which kind of goes with this leakiness. Sodium and H2O water is flooding the membranes. That's what's causing a lot of this swelling. And then with that, you have this mitochondrial damage. And so there is a lot happening at that cellular level. And with that, you start to see this change from aerobic metabolism to anaerobic. And so with aerobic metabolism, that is how we normally function. So when you think aerobic, glucose, oxygen go into the cell, outputs CO2 and water, and energy is produced. And so with aerobic, it uses glucose and oxygen, then produces CO2 and water, and that kicks that out of the cell, and that produces a lot of energy that way. And so normally the body functions under aerobic. When you have anaerobic, usually that is using only glucose. And so only glucose goes into the cell, and then lactic acid gets kicked out. And so that releases a small amount of energy and creates an oxygen debt to break down all that lactic acid. And so the big thing is recognizing when patients start to develop shock, they have that inadequate tissue perfusion. We're not getting enough oxygen in. So there's not enough oxygen to do aerobic metabolism. And so they switch to anaerobic, and that causes a buildup of lactic acid. And so there's a lot of cellular changes that happen. You also have activation of a stress response, which causes increased glucose levels, increased glucose, decreased insulin, and then the body becomes more insulin resistant. And so body's not able to utilize the glucose. which really decreases the glycogen reserves. The body starts to get energy from protein. Body doesn't have enough nutrients and O2 for that normal cellular function. And so really, we start picking up on all this shock. All has to do with not getting enough oxygen to the tissues. And then another big cellular change that happens is the clotting cascade. Usually the clotting cascade is going to become overproductive. You'll start to see like small clots, which can lead to decreased cellular perfusion because you start to get these mini clots building up here. So these big cellular changes relate to that increased permeability. Whoops, went back. Increased permeability, the activation of the stress response, and then you see the clotting cascade happen. Then you go down to these vascular responses. And so with the vascular response, you have the release of cytokines. And so that stimulates vasodilation or vasoconstriction. And so that is why you see typically a lot of vasodilation in when patients are experiencing a shock. And then you have blood pressure regulation. And so when we think about blood pressure regulation, we really should be looking at our MAP, our mean arterial pressure. And so our MAP really is just our cardiac output times our peripheral resistance. And so tissue perfusion and organ perfusion depend on that mean arterial perfusion. And so our MAP, we really need to maintain that over 65 to maintain that adequate tissue perfusion. So also keep in mind the RAS is going to, play into this as well. And so as you guys know, the kidneys help regulate blood pressure. If they're not getting perfused, the RAS is going to kick in. And so with that, you have angiotensin 1, has the conversion over to angiotensin 2 and causes, vasoconstriction. And then you also have the ADH kick in, the antidiuretic hormone, and causes the kidneys to not retain water to help increase the blood volume and blood pressure in these patients. And so that's going to be more of a compensatory mechanism to help with that. So when we get into the stages of shock, there are your compensatory, your progressive, and your irreversible. So for your different stages of shock, the compensatory, that's going to be, the body's trying to start compensating for what's going on. So the blood pressure will usually remain within normal limits here. We see release of those biochemical mediators, those cytokines, they start to cause some vasoconstriction. So you'll see heart rate go up, you'll see increase contractility, body starts to shunt blood to the vital organs, so the heart, the lungs, the brain. And so the body is just trying to, compensate there. Well, as this shock progresses, you move into the progressive stage of shock. So that's the second stage of shock. And now you start to see some changes in that blood pressure. So your MAP is going to fall below normal limits. Typically, the systolic blood pressure is going to drop to less than 90. Or if the patient is usually hypertensive, they're just going to have a drop of like 40 millimeters of mercury from their baseline. So if they're normally 160 over 90, they may be like 120 over 70. And so they start to have a drop in their blood pressure. And with that, you may see some mental status changes in that patient. First, the overworked heart's going to become dysfunctional. The heart's going to stop, is not going to be, functioning at its optimal level. And then secondly, this is where you're going to start to see that increased capillary permeability from that inflammatory response being, initiated. You may also see that coagulation cascade, that clotting cascade get activated. So you might start to see some microemboli, which can cause, other issues within the body. And so, that progressive stage of shock is just going to be continuing to get worse. Then you move into the irreversible. And so that's exactly, what it states is irreversible. The patients aren't going to recover from this stage of shock. And so with this, the organs are so damaged, the patient's not going to respond to treatment and can't survive. And so sometime within that progressive stage, these patients switch over to irreversible and there's no coming back to it. And so it's important to understand just the stages of shock because it shows what the body's doing. And then you have this flowchart over here under physiology, pathophysiology, that just shows that there's this initial insult that leads to shock. And we're going to get into all the different types of shock. And with that, you have that decreased tissue perfusion and oxygenation, which is what shock is all about. The tissues aren't getting perfused. There's not enough O2 get into the organs and tissues. So then our homeostatic response system kicks in. We try to start compensating. So we have our sympathetic response. We have that increased heart rate, increased blood pressure, increased cardiac contractility, which all leads to the effort to get cardiac output up to help perfuse the organs better. You have the RAS kick in. So you have that reabsorption of sodium and water, which leads to increased preload. You may see decreased output. And so you got all these factors that hope to restore tissue perfusion and oxygenation. On the other side here, you have the respiratory rate goes up because the lungs are trying to get more oxygen to send out. You have catecholamines and cortisol to provide, that increase glucose for metabolism as well, to all try to get oxygen to the different tissues. So that's kind of how shock progresses. And so there's all different types of shock. And so regardless, shock for the most part is going to be treated the same. So you have cardiogenic shock, and so that's going to be a result of when, there's been something that happens to the heart. Circulatory. Circulatory is kind of a broad statement for shock. There's hypovolemic shock, there's neurogenic shock. Circulatory is sometimes interchanged with distributive, and so with distributive, that's where your septic shock is going to fall in. So like I said, we're going to get into all these different shocks. So regardless of the type of shock, early identification and timely treatment is imperative. Shock really needs to be identified early so we can start initiating treatments. The longer it takes for us to identify the patients in shock, the less likely the patient's going to have a positive outcome. So it just comes down to identifying and then treating the underlying cause. So if the patient's hypovolemic, give them some fluids. It's a little more complicated than that, but, just treat the underlying cause. The sequence of events for the different shocks will vary, but the management of these patients is very similar. There's just, specific management or nursing interventions we do for each type of shock. Like if the patient's septic, we're going to give them antibiotics, whereas you want to give a patient that's hypovolemic antibiotics if they don't need them. So lots of different ways to treat shock. So I'm going to first get into just the general shock management. So this is going to be appropriate for all shocks. And so first off, you want to make sure you're supporting the respiratory system. So these patients are either going to be on just supplemental O2, through nasal cannula, but as the shock progresses, they may end up mechanically vented so they can, provide optimal oxygenation with the assistance of a ventilator. Then there's going to be fluid replacement to restore intravascular volume. And so with that, there's different types of fluids for shock. And so they're going to be administered to improve cardiac and tissue oxygenation. We're going to be giving these early in shock. So you can see normal saline or LR given, so LR, lactated ringers. Because that patient is losing so much fluid into the interstitial space due to that increased capillary permeability. And so with that, I said you can give normal saline or LR. A lot of times you'll see LR given more often because it has this lactate ion in it. And so don't get confused. That lactate ion is actually contains a bicarb, and so it's going to help buffer. And so LR and normal saline are both isotonic fluids. So you'll see in the image over here. And so those are going to be used to help expand volume. And they are the most commonly used fluids for fluid resuscitation. You just have to be careful when you're giving a lot of fluid because you can throw those patients into fluid volume overload. It can cause pulmonary edema. You may even see it cause abdominal compartment syndrome, where there's too much pressure being built up in the abdomen. So you just really have to watch those patients for, signs of too much fluid. Then there's colloids, and so crystal and colloid solutions. And so for colloids, those are going to be similar to plasma proteins. Molecules are too large to pass through that capillary membrane. And so that's going to be like albumin, plasminate. Those are really, those are volume expanders. And so you don't see those used as often because they are honestly quite pricey. And so just to get some excess volume into patients, they'll, give them normal saline or LR. And so just being aware that there are a lot of different fluids. Again, like I said, a lot of the complications of this fluid administration is going to be cardiovascular overload, can cause pulmonary edema. And so think about, how do you know that your fluid resuscitation is successful? One, you can be looking at their urine output. If they start to produce adequate amounts of urine, that shows us the kidneys are getting perfused and that fluid resuscitation has been successful. You can also think about back to when we did some hemodynamics. If these patients have a CVP line, so that central venous pressure, that tells us a lot about our patient's fluid status. And so if you remember, a normal CVP is 2 to 6. So if they start to have that increase in CVP, that's going to show us that they're starting to maintain their fluid volume status. And on the other side, how are you going to know that the patients are becoming fluid volume overloaded? How are they that they're hanging on to too much fluid? A big sign of that is going to be looking or listening to their lung sounds. What are their lung sounds? Were they, clear to begin with, and now we're starting to hear a lot of crackles? Might need to back off on the fluid resuscitation. And the other big complication is these patients are going to be sick, so they're probably going to have that central line like I was talking about with the CVP, or they may have an arterial line. They could even have a pulmonary artery catheter. Well, if you remember, any of those invasive lines puts those patients at really big risk for eclampsia, a central line associated bloodstream infection. And so you really got to monitor those patients for infection, making sure those dressings are inclusive. Another aspect about shock management that I wanted to mention that's not up on this PowerPoint is these patients are going to need nutritional support to address the metabolic requirements, and you'll also see them on vasoactive medications to restore vasomotor tone and improve cardiac function. And so we'll talk about each of those in a little more detail as well. So getting into, further shock management with these vasoactive meds, just think about, vasoactive meds. And so when you think vasoactive, that can either cause constriction of those vessels, it can cause them to clamp down, or it can vasodilate. So you're going to vasoconstriction or vasodilate. In shock, you're almost always going to see vasoactive medications that are causing vasoconstriction because we need to get that blood pressure up. And so vasoactive meds will, increase myocardial strength. They're going to help regulate heart rate, reduce myocardial resistance, and just initiate that vasoconstriction. And so these meds will be selected by their action. And so you're going to have inotropes. Those really help with the squeeze. The vasodilators, like I said, will vasodilate. And then vasopressors. And so this next slide, we'll talk about those a little bit more. But when you have a patient that's on these vasoactive meds, it is so important that you are monitoring vital signs. These patients are going to be getting vital signs. They'll be on a cardiac monitor. They'll probably have an arterial pressure, a MART line that's giving them these continuous blood pressure readings. And so it's really important that you are being, really good nurses and monitoring their vital signs closely. And then this last bullet point here, titrating vasopressors. So vasopressors can be titrated to maintain certain blood pressure. And so we talked about MAP, your mean arterial pressure. And so in clinical, you go get vital signs, your blood pressures, 120 over 80, and that gives you a specific MAP as well. I don't know what that MAP is off the top of my head, but it's definitely above 65. And so you'll titrate these vasopressors to keep that blood pressure, at a certain level, and to keep that MAP. Usually it'll be, titrate to keep the MAP greater than 65. And so when you're titrating those, you definitely have to be paying close attention to the vital signs. And you never want to just go in, say your patient's running on norepinephrine, this levofed, and say it's running at like 5 mics, you never just want to shut that off. You need to titrate that down slowly to make sure, give that patient, time to compensate and get them off that medication. So here's this chart in your book that talks about vasoactive medications. And so you have your inotropes. And so that's going to improve contractility, increase stroke volume, increase cardiac output. But then it tells you about the disadvantages, increases oxygen demand on the heart. Then you have your vasodilators, then you have your vasopressor agents. And so you'll notice that there's some medications that are listed as inotropes and vasopressors. And so that comes down to usually at lower doses, dopamine, maybe an inotrope. At higher doses, it may be considered a vasopressor. And so you can see multiple uses for these medications. Like I said earlier, nutritional support is really important in these patients because they have this increased metabolic rate. So these patients need more energy, therefore they need more calories. Oftentimes they're going to need about 3,000 calories. These catecholamines get released early in shock, and so that depletes the glycogen storage, and so that's why it's so important that we're giving these patients some type of nutrition. And it helps cut down on stress ulcers. So enteral nutrition is going to be the preferred method. That means they're getting their feeds through a tube feed and not through like TPN through the IV. And so giving them these tube feeds is going to help reduce stress ulcers, because stress ulcers may occur frequently because the body has shunted, blood to the vital organs. So that means the GI tract is not necessarily getting enough blood. And so feeding these patients will help reduce those stress ulcers. It's also important that these patients are put on some type of antacid or H2 blocker, PPI, because those will help inhibit gastric acid secretion and therefore will decrease the possibility of a stress ulcer. So now we're going to move into the specific types of shock. And so first we'll start with hypovolemic shock because this is the most common type of shock. And so with hypovolemic shock, you have this decreased intravascular volume. It occurs when there is a reduction in intravascular volume by 15 to 30%. So that patient has lost about 750 to 1,500 mils of circulatory blood or fluid, and so they're hypovolemic. And so that can be caused by dehydration, severe edema, ascites, so you got, shifting of fluids, or blood loss. They've hemorrhaged for some reason. Maybe they had surgery, or they were in like a accident. They've had some type of severe trauma where they're losing a lot of blood. And so it's all about, there's this decreased intravascular volume. And so with that, there's a sequence of events. And so you can kind of see that over here in this flow chart, but you have decreased vascular volume, which leads to decreased venous return. And when you have decreased venous return, you have decreased ventricular filling. And so that's going to lead to decreased stroke volume, and then, which then causes decreased cardiac output. And with that, you have decreased blood pressure. So these tissues aren't getting perfused. And so tissues not getting perfused, there's not enough O2 getting to them. And so you can see lactic acid start to be, because that's where we flip from that aerobic metabolism to anaerobic metabolism, which causes that increase of lactic acid. So to treat hypovolemic shock, first you got to identify and treat the cause. And so if the patient's bleeding, stop the bleeding, give them blood. If they are losing fluids because they're, nauseated, vomiting, have diarrhea, got to stop the diarrhea and vomiting. If the patient's just extremely dehydrated, which you might see in some, like the elderly patient population, we got to get them rehydrated. And so we are going to, replace the fluids and blood, in their blood if that's what's going on with them. And so fluid replacement is going to be the primary concern, the biggest intervention we need to do. And so to replace this fluid, we need to make sure that patient has, 2 large gauge IVs. So you're looking at like 18 gauge or larger. And so this will be replaced on the 3-to-1 rule. So 3 mils of crystalloids for every mil of blood loss if it's, if the patient's losing blood. And so it's really important that we're just getting those fluids replaced. You can also do redistribution of fluid, and so that involves the modified Trendelenburg position. And so you elevate the legs, that promotes return of blood back to the heart. And so it just promotes that venous return of blood. Meds are also given to reverse the cause. So say the patient is having diarrhea, that's when you'll give them a anti-diarrheal med, or if they're having nausea and vomiting, you give them antiemetic, Zofran, Phenergan. Or think about your DKA patients. They've had that osmotic diuresis. They've now became extremely dehydrated. Give them maybe, got to treat that cause and give them insulin due to that hyperglycemia. And so, those meds are going to target whatever has caused this hypovolemic shock to begin with. Over here is just a picture of the modified Trendelenburg position. You see the legs are up. It helps to promote blood return to the heart. You'll see them put in Trendelenburg if the patient becomes hypotensive. You flip them into Trendelenburg real quick in hopes to try to get their blood pressure up. It's really important that you make sure you're administering bloods and fluids safely. You're implementing safety measures. So you always need to make sure you're documenting what you're doing, monitoring for complications and side effects of treatment. Think about, what are you going to be looking at in this patient population? Well, one, vital signs are going to be really big. Be looking at their blood pressure, their heart rate, watching the respiratory rate to make sure we're not, fluid overloading them, watching their O2 sat. You'll be looking at their CVP, listening to lung sounds, monitoring lactate levels. With that, you can be monitoring ABGs to make sure these patients aren't becoming, acidotic or having, an acid-base imbalance. Monitoring for, the other fluid volume overload complication of abdominal compartment syndrome. We're giving these patients all kinds of fluid, so making sure they're not becoming hypothermic. And then another intervention is, we're just going to give oxygen because that increases the amount of O2 carried by the hemoglobin in the blood. And so giving those patients oxygen is going to be another big intervention for them. So that was hypovolemic shock. Now we're going to get into cardiogenic shock. And so cardiogenic shock, that occurs when the heart's ability to contract and pump is impaired and the supply of oxygen is inadequate for the heart and tissue. And so heart can't pump effectively. We have that decreased cardiac output, and where the heart's not getting enough oxygenated blood out to the rest of the body. So you have decreased MAP, decreased cardiac output. And so there can be a lot of reasons that have, caused this. The patient may have had an MI, or, they're suffering from, they had suffering from this heart attack that affected their left side of the heart, and now the heart can't pump as effectively, or they've developed severe heart failure. And so anything that has impacted the heart can lead to cardiogenic shock. And so you might see them develop angina. They might have dysrhythmias, fatigue, may just have this overall sense of impending doom, and these patients will be very hemodynamically unstable. And so one of the biggest interventions we want to do is just limit further damage. And so we want to look to correct the cause of this cardiogenic shock. And so we'll improve cardiac function we'll try to increase cardiac contractility and decrease ventricle afterload. And so this is going to be achieved by just increasing O2 to the heart muscle, while also reducing the O2 demand. So these patients will be put on oxygen. Might try to maintain their oxygen sat at least 95% for this patient population. Might be giving them morphine, because if you remember, morphine is going to have more than just an impact on pain control, but it also decreases preload and decreases afterload, which is going to take some demand off the heart. These patients under hemodynamic monitoring will have an art line to get blood pressure, also an art line to easily get ABGs drawn. They may have a pulmonary artery catheter to give us specific measurements about cardiac output, as well as systemic vascular resistance, how hard that heart's having to pump to overcome that SVR, that systemic vascular resistance. Labs, we'll be looking at BNP to see, how bad that heart failure is. That B-type natural peptide is that enzyme that gets released when the left ventricle gets stretched too much, that you see in heart failure. Be looking at cardiac markers to trend them if the patient's had an MI, looking at the telemetry, 12 lead, looking for ST segment changes. And then we have to be really careful with fluids for your cardiogenic patients, because we could really easily give them too many fluids and throw them into fluid volume overload. And so medications are going to focus on improving contractility and decreasing the cardiac workload. And so you'll see that those are kind of imposing actions. And so we had talked about with those vasoactive medications chart, you have your inotropic effects. They stimulate the myocardial beta cells. So it's going to be your dobutamine, dopamine. And so those are both going to help with cardiac contractility. And like I said, dopamine at low doses is what really helps with the contractility. At high dose, like when it gets above 8 mics per kilogram per minute, that is where you're going to see that dopamine cause vasoconstriction. One of the reasons dopamine helps with that contractility is you also will see increased heart rate with that, which helps with increased cardiac output. The nitro, those are going to be your vasodilators. Those will reduce preload and reduce afterload. And then your common, other common medications given are going to be your Levophed or norepinephrine, same medication. Epinephrine, another vasopressor, phenylephrine. I mean, you might just going to see all your vasopressors given. And then you'll also see antiarrhythmics given. And so that'll be like amiodarone, lidocaine. And so, try to pull back all that cardiac information, because that is really going to be pertinent when we're talking about the treatment of cardiogenic shock. And so one of the best things we can do for cardiogenic shock is, try to prevent it or identify, increased patients at risk for potentially going into cardiogenic shock, because it's hard to really prevent this, but we can kind of stop the progression just by, monitoring every patient closely. If they're having, angina, help relieve that, giving them O2, reporting findings promptly to the physician, kind of anticipating where these patients may be heading towards. Nurse must know desirable effects of medication. So if you're starting this patient on a low dose dopamine drip, so say you're starting a patient on dopamine at 2 mics per kg per minute. So that's going to be a low dose dopamine. And so like I said, that is really what's supposed to be helping with the contractility of the heart. And so you should be looking for that increased cardiac output. And so just understanding, your medications is really important and the side effects of those, as well as always make sure you're assessing those IV sites, because these are all going to be medications that are vesicants. A lot of these heart meds, these, vasoactive medications are vesicants, so they can be dangerous to the vessel if those IVs would infiltrate and cause a lot of damage to those tissues. And so make sure you're monitoring those sites closely. Maintaining the intra-aortic balloon pump, that's what your IABP is. And so I'm just going to go back a slide. So this image right here, it shows you what an intra-aortic balloon pump is. And so this would be this mechanical assistive device. So the purpose of a balloon pump is it is going to inflate during diastole. And so this will, let me back up, this will go in through the femoral artery generally and go up into the aorta, and it is a long, kind of narrow balloon that just sits up in the aorta, usually at the distal third of the aortic arch. And so it is going to inflate during diastole. And so part of that is it helps push blood actually back into the coronary arteries and reperfuse the heart. And it takes a lot of workload off the heart as well. And so this balloon pump helps kind of let the heart recover, particularly after the patient had like a significant MI, and so allows the heart to recover. And then just make sure you're enhancing your patient's comfort and safety, just reducing their anxiety, thinking about their positioning. Like if they have that balloon pump in, they're going to need to, keep their head fairly flat, just like they would post-cath, because that could, damage the artery, could cause an RP bleed. Okay, so now we're going to talk about distributive shock. And so distributive shock occurs by when there's been this intravascular blood volume, basically just pools in the peripheral, so pools in the periphery and the blood vessels, and it's going to be caused by usually this loss of sympathetic tone or released by biochemical mediators. And so you're going to see that in like sepsis, anaphylaxis, and neurogenic shock. So regardless of what type of shock has caused this, distributive shock, in all types where you will have this massive arterial and venous dilation, and so that's what's going to lead to this peripheral blood pooling. And so we're going to focus mostly on septic shock. We'll get into neurogenic shock later on in the semester. And then I'll talk briefly about anaphylactic shock. And so anaphylactic shock is just, there's been like a transfusion reaction. There's a reaction, to, some type of like by like a bee sting, or the, a lot of times people have a peanut allergy. They have an anaphylactic reaction to peanuts. And so food allergies can play a big part of the anaphylactic shock. And then like we treat those patients with epinephrine. So we're not going to do much with the anaphylactic shock. Like I said, we'll focus more on septic shock. And so with that, you see that tend to happen more in like immunocompromised patients, increased age, they've had some type of invasive procedure, there's something that's led to sepsis. And so with this, there are, a lot of risk factors for, these types of shocks. So think about what those risk factors could be. So like specifically for septic shock, we said the immunosuppression, so patients that have had like, some type of organ transplant, or, there's lots of reasons why, or they're undergoing like chemotherapy right now, so they're immunosuppressed. Age, I mentioned, the elderly, but also they're really young, so typically less than a year old or greater than 65, you'll be at bigger risk for septic shock. Malnourished, chronic illnesses, invasive procedures, like I said, emergent or multiple surgeries, those are all big risk factors for shock. But if you look at this table here on page 314, chart 14.5, it goes into a lot of the risk factors for like neurogenic shock, which is mainly just spinal cord injury, spinal anesthesia. And then we talked about the anaphylactic shock with the food allergies, bee stings, transfusion reactions from like blood transfusions. And so those are the different types. And so just remember, distributive shock just has to do with basically intravascular blood volume just starts to pool in the periphery. So you have, really bad decreased venous return, which leads to decreased cardiac output and that decreased tissue perfusion. So furthermore about sepsis. So septic shock. What is sepsis? Well, it is the most common type of distributive shock. And so there has been some type of infection. These patients become septic. They then become severely septic, and that leads to shock. So that's why it's so important that we follow the bundles, like the CAUTI bundles, so the catheter-associated UTI, make sure those patients aren't developing an infection that way. The same with, ventilator-associated pneumonia, following those bundles, maintaining, sterile technique and procedures that need sterile technique, like catheter insertion, dressing changes. It all starts, with following, the protocols, and, comes back to what's the number one way to prevent infection? That is hand hygiene. So it all starts with hand hygiene. And so with sepsis, you have this bacteria or microorganisms, they invade the body. And so that leads to, kicks off that inflammatory response. Patients start now to have that poor tissue perfusion. You start to have that increased capillary permeability. With that, you may see vasodilation, the clotting cascades activated. And so that's why shock is generally, even though there's different types of shock, it all kind of comes back to the same, patho of inflammatory response kicks in, increased capillary permeability, vasodilation, clotting cascade kicks in. And so with this one, specifically for sepsis, in the early stages, initially that blood pressure is going to be normal. They may start to show decreased response to fluids. You have that increased heart rate. But think about, this patient has an infection. And so these patients are going to have a fever, which is going to lead to warm, flushed skin for sepsis. Patients may also start to experience bounding pulses, increased lactate, because it might be starting to switch over to that anaerobic metabolism, and they'll start to see altered mental status. And so that's what's going to happen with that early stage of shock. Then as you get into that progressive stage, these tissues become less perfused and even more acidotic. All the compensatory mechanisms begin to fail, and so now that's when you're going to see the blood pressure decrease, the patient's not responsive to treatment, and so the sepsis is now, you're in full-blown shock. Blood pressure is decreased, patients are cool and pale and mottled, and so mottled means that skin is like purplish looking. They have decreased temperatures, the urine production has ceased, so the kidneys are, starting to fail, and these patients are progressing into multiple organ dysfunction, or, all the organs are failing. And so if you look over at this image over here, like for this particular patient, there is probably a pneumonia infection, there's an infection in the lungs, bacteria enter the blood, so now they're getting septic. You see this increased capillary permeability, and now that's going to lead to organ dysfunction. And then there's also SIRS, the Systemic Inflammatory Response Syndrome. And so that's similar to sepsis, but there's not an identifiable source of infection. So they have all these symptoms of infection. Their temperature is elevated, so it's usually greater than 38, or that you might see actually lower temperatures, less than 36 degrees Celsius. Their heart rate starts to elevate, greater than 90. The respirations go up greater than 20. White blood count starts to go up, but we can't identify what's causing this infection. And so you'll see this in patients where you're trying to rule out a UTI, you draw blood cultures are negative, nothing's growing, you get a respiratory culture, nothing's growing there. And so that would be like you pan cultured that patient, but you can't figure out what's going on with them. So that's when they get identified as SIRS. And so early identification in all types of shock is important, but particularly with sepsis, early ID is critical. It needs to be identified within 6 hours. And so you'll culture these patients, like I said, blood, urine, sputum cultures. And so you need to make sure you get all these cultures done before you start giving them antibiotics. And so you need to get that first initial dose of antibiotics in within like the first 3 hours of treating them. So make sure, like initially, because it'll take up to like 48 hours for all these culture results to come back, you can start treating them with broad spectrum antibiotics. And once you identify specifically what type of bacteria is grown, that's when they'll switch the antibiotics over to a specific medication antibiotic that will treat that patient. You'll start these patients on fluid replacement. If fluids aren't effective, then you'll switch them over to, meds. Typically, you'll start them on pressors, so that Levophed or norepinephrine or dopamine to try to keep their MAP greater than 65. You also want to make sure that they have a normal H&H, or at least a hemoglobin that is above 7. And so if their hemoglobin drops below 7, you'll see PRBCs given, packed red blood cells, because think about it, the patient's not getting enough oxygen to the tissues. If they have a low hemoglobin, if they're anemic, that is even less oxygen to the tissues. You'll need to think about DVT prevention, making sure that patient doesn't develop blood clots in the leg, because they can navigate, up to the brain or lungs. And because this patient probably has already had the clotting cascade activated, so they may be more likely to develop clots that way. Stress ulcer prevention, so those early feeds as well. Other nursing management, again, I can't emphasize enough the importance of making sure you're using aseptic technique on all invasive procedures. Monitoring the patient when we do, just monitoring the patient, making sure, monitoring for elevated temperatures. Labs specifically, looking at procalcitonin levels. And so procalcitonin is a newer lab to identify sepsis. And so typically, if you have a procalcitonin level of 0.15 to 2, that indicates there's some type of infection going on. And if that level gets above 2, those patients are likely septic. And so that's a newer lab to help identify sepsis. But other than that, monitoring white blood count, monitoring the BUN creatinines, watching the C-reactive protein because that shows inflammation within the body. And then there's the antibiotic peaks and troughs. And so those will need to be done for appropriate dosage of antibiotics, looking at your coags, your PT, INR, your platelets. And so those are all, really important just to help, monitor these patients that are septic and monitor them to help prevent them to going into or start the treatment earlier if they're going into shock. Table 14.4 in your book, it's on page 317, is the SOFA. It's sepsis-related organ failure assessment score, and so it looks at, respirations, it looks at the coag labs, liver function, cardiovascular, and so it gives them, for like patients that aren't in the ICU setting who has an infection, it can give them the score to help screen for the development of, sepsis, potentially shock. And that also leads me to the MUSE score, which is the Modified Early Warning System score. And so you guys may have seen this in clinical, but the MUSE is great for just helping, track vital signs basically, as well as level of consciousness to pick up on, any minor changes in that patient that may indicate that they're starting to decline. And so it's just an extra safety check for the nurse. To help catch these patients before they get too far into the sepsis. So that leads me to MODS, so this multi-organ dysfunction syndrome. And so this is going to be this irreversible stage. This is that last phase of the shock state. And so this is most commonly seen with septic patients. Usually this will begin in the lungs. The lungs are usually the first organ to show dysfunction, like when ARDS develops. You also see it in the cardiac, GI system, renal, kidneys will start to fail as well. And so this is just, we've gotten to that last stage of shock, this irreversible stage, and all the organs are starting to shut down. And so I said the lungs will start to be the kind of the first telltale sign of this. They require them, going to start requiring more support to keep that patient stable, require more ventilating or higher event settings. You'll see BUN go up, lactic acid's going to go up, and every system's going to start to fail from there on. Kidneys aren't going to be producing urine, so BUN and creatinine are going to go up. Liver is going to fail, so the patient's going to be more susceptible to bleeding. The cardiac system is no longer going to respond to medications, so we're giving them all these vasoactive medications to improve their blood pressure, and they aren't responding at all to that. And so those are some of the different clinical manifestations you're going to see in this. I mean, I've had patients before where they're maxed out on all the pressors we could possibly put them on. They are extremely mottled because when you think about pressors, those are clamping down all the vessels, so they're not getting blood flow to their toes. And so their toes are starting to turn, beyond mottled. They're turning black because there's no blood flow to them. And so basically, we're doing all this treatment, but the patient's not responding to it whatsoever. And so as far as medical management, the first thing you can do is try to control that initiating event and promote adequate organ perfusion, do the nutritional support, and then, as that shock progresses and they get into this MODS, there's no coming back from it. So you just have to maximize that patient comfort. And then as far as nursing management, it's just going to be, you're going to continue to treat them until, it gets identified that the patients aren't going to return. So you'll, just continue to treat them like you are any other stage of shock. And since this is, typically associated with septic shock a lot of times, so you'll just, keep treating them as if they were a sepsis patient. And then you move on to, you need to support, the family members. You need to address like end-of-life care. You need to really be promoting like open communication, being there to educate the patient's family members about what's going on. You never want to give them any false hope that they may recover from this, because once they're in MODS, unfortunately, they're not going to recover. All those organs are going to fail, and those patients are going to pass away. So it's really important that we are, having those open communication lines. So this presentation was just meant to be an introduction to shock. I will go into it more during our Friday lectures, but as you're, preparing, listening to this lecture, reading, start thinking about like your top 5 takeaways for shock, because that's, just kind of start that conversation on Friday. The other thing I want you guys to do is, let me pull this up real quick. Let me switch my screen. Give me just a minute. Okay, so I want you to get on Canvas under the module for exam 4 and pull up the stages of shock chart. So basically up here it has compensatory, progressive, and irreversible. And I want you to help fill this out before Friday, because during Friday's lecture, we're going to fill this out together. And so for compensatory, what is compensatory? What is happening within the body? And so like that's where that blood pressure is remaining normal. You might see some vasoconstriction, the heart rate's going up a little bit. To increase that contractility, you start to see that shunting of blood. And so just fill out, what's going on in the compensatory. And then further on, what's that going to look like in all these other systems? This all just help you out. Like for respiratory, you see this increased respiratory rate. Why is that going on? Cardiovascular wise, the blood pressure is still within normal limits. And so just look at what's going on, and then move over to your progressive. And so this is, the mechanisms that regulate the blood pressure can no longer compensate. And so what starts to happen there? And then when you get to the irreversible, what's going on there? Well, that, organ damage is so severe, the patient's not going to respond to treatment. And so what's that look like? Well, I'll give this one away. For MODS, everything's failing. So the respiratory system's going to fail, cardiovascular, they have decreasing blood pressure, it's not responsive to treatment. Neurologically, these patients are going to end up, being unconscious. Kidneys are going to fail, your liver is going to fail. And so just go through and look at that. And then the last thing, just identify some of the main treatments for these patients. How are we going to manage them, medically and nursing wise? And so start filling that out. But like I said, we will go through this together, and I'll, post a completed chart for you guys, but I want to talk to you about it first on Friday. And so that concludes this lecture. Of course, I will, be answering any questions on Friday. If you have a burning question that can't wait, feel free to email me or set up a Zoom session, and I will see you guys on Friday.